Assalamu alaikum, everyone. Um, First of all, I would like to thank the PSIM team for giving me this opportunity to speak in front of my lovely teachers. I'm very grateful for all the love and passion to teach me that, whenever I'm here, present in front of them, it's an emotional event for me. Dr. Javed Akram is here, Professor Azur Rahman, Professor Sajid Ubaidullah, Tariq Wasim, Aftab Mohsin, just to name a few. So thank you, thank you, thank you. As we talk about the diabetic nephropathy in 2023, and the reason I picked the topic with the timeline, because we see evidence-based medicine and evidence up now, right? What's the slogan? Did I miss something? Evidence-based medicine up now. The beauty of the evidence is that it keeps changing and it's evolving. So I think 20 years ago, that slogan was not there. So this is a huge progression. I'm very happy for that. These are some of my disclosures. Thank you, Dr. Umar Farooq, for the kind introduction. So I work at Penn State Health Virtue Medical Center. Some of my active clinical trials which are ongoing or listed, worth mentioning is this Figaro Fidelio trial, which is the MR2 blocker. And this was by Bayer. It's completed, and I will be presenting that trial today. There are some trials going on for the renal denervation and resistant hypertension and some glomerulonephritis, which are listed, which are beyond. I don't think I'll be talking about them. So you'll be talking about DKD, which is diabetic kidney disease. That's kind of the new term coined for diabetic nephropathy, and CKD, which is chronic kidney disease, and how we have lost the last 2 decades. So really, I think we just heard about some magic drugs, the timeline that 20 years ago after the invention or approval for the ARBs, we were all happy, but then it took nephrologists and all the community 20 more years to reach to some new dimensions, new guidelines, new drugs. I will be presenting the major trials in the nephrology world, which has impact not just nephrology, but beyond nephrology as well. Sometimes, these trials, when you go through, things may get boring, right, Dr. Unger? In the middle, the people lose. And if I lose your attention, that's fine. In the very end, I will try to bring you what's in for you, how we can reach to a comprehensive care model. And I have developed this algorithm, which is ABC. It used to be just ABCD, but now I have added EFGS to that algorithm. So it might be easy for you to remember. So the last 2 or 3 slides, make sure that you pay attention. So let's look at the 5-year survival of diseases related to kidneys. Dr. Azazman is sitting here. He's my colleague nephrologist, and he can just look at it as well along with me. So somebody has CKD, we do dialysis, we do transplantation. Transplantation is done. सबने सोचा भाई ठीक है, अभी अब ट्रांसप्लांट हो गया है, अब तो मरीज बच गया, आपने सारा कुछ बंद कर दिया. But in reality, you see these pink bars. Whether this is living donor or deceased donor, and this is European data, I can reassure you American data is not going to be much different. Maybe Canadians do better dialysis than Americans. So the transplant outcomes are, still inferior to some of the common cancers. But when you talk about hemodialysis and PD, they are barely, the 5-year survival is barely beyond pancreatic cancer and lung cancer. So it makes me feel sad to report that the outcomes of dialysis are actually not different from some of the aggressive forms of cancer. And this slide just gives you the idea that if you are young, say you are in your 20s and you start dialysis, this will cut or chop the last 40 years of your productive life. So dialysis really decrease your lifespan. And we all know that. You go to dialysis and you have all the patients who start with CKD, once they hit the dialysis, I think it's a death sentence, unfortunately, for some of our patients. And this is not different. You know, Pakistan, I understand how the demographics are, but this is true for many other places. And really, the biggest driver is the cardiovascular risk factors, not necessarily the renal. So this is a hypothetical model. I think this was presented by Dr. Fink. He published this back in 2009. And we all of you in the internal medicine, primary care, different subspecialties, hospital medicine, you see all this. That just think about a patient who has CKD, then we treat them with NSAIDs for gout. There is this decline in the GFR. They go to our cardiology office, they get contrast, they get heart cath, and then there is a further decline. They get some medication which are nephrotoxic, and they hit my clinic or Dr. Azazman's clinic. The problem is, by the time they reach to my clinic, पानी तो bridges के नीचे से गुजर गया होता है. They are either very advanced CKD or they are approaching end-stage kidney disease. But if you think about the top line, it says the baseline rate of renal function loss. That's the time they are in your clinic. That's the time when it all started. So my ask to you is that, what can we do that instead of having a slope like this or a slippery slope, can we have a slope which is more flat so patients don't hit all this and go to dialysis and you can save their life? This is what a kidney can do for you. It's the powerhouse for the metabolic waste management, volume, electrolytes, blood pressure, acid base, red cell production, vitamin D, and drugs. So you see that these metabolic organs are really at the heart of some of the diseases that you see. How do we define the chronic kidney disease? And I believe this is important. We understand the beast and the problem we are dealing with. So it's chronic, so it has to be, there must be some timeline. It says more than 3 months. So if somebody has an AKI or acute kidney injury, they get better. We don't call them chronic, but this is something which is there for more than 3 months. And 2 markers are important. So one is the GFR, and one is the albuminuria or protein in the urine. So 2 markers are important for CKD. For AKI, the 2 markers are creatinine rise and urine output. For CKD, this is GFR and albuminuria. So CKD staging, again, you see these patients, and I think some of the new things were, so it's based on the GFR category, you divide them in stages. How I describe this is the percent function in both kidneys for my patients. So when they come to my office, the GFR is 50. I said, you have lost 50% of function in both kidneys. It just gives them an easy construct to understand. Although I give them the disclaimer that how the normal is above 100, and then this is how when you have less than 15, it's practically loss of 90, 85% function. So you know all these stages. The 3, which was the widest stage between the GFR range of 30 and 60, is further broken down into 2 more categories, 3A and 3B. When you combine with the albuminuria stages, so now there is more staging with the albuminuria, so you quantify the albumin and you assign the stages A1, A2, and A3. This is really a progressive, so if this is less than 30, that's A1. A2 is between 30 and 300, which is the micro albuminuria. You all are aware of that. And A3 is the macro. Now this albuminuria, proteinuria was a bit confusing, and it has been confusing to everybody based on different units, how we measure this. So either this is protein excretion rate, which is the classic 24-hour protein we have been doing on the right-hand side. So it's normal is between 50 and 150, but this is milligram per day. You do a timed collection, and you can have albumin excretion rate. Albumin is kind of, maybe half of the protein in the urine is albumin. So you see the normal is like 10 to 30. Similar, the ACR is albumin to creatinine ratio, and you see all these labs are reporting. So I thought this is very relevant. And that's a ratio, that's a timed spot urine. It's not at 24-hour or 12-hour collection. So that's easy for patients to measure as well. We just saw a very nice heat map in Dr. Ungar's presentation about hypertension and how you based on the blood pressure targets, you actually try to improve their risk factor as well. Here the risk factor is proteinuria. You see the color changes as the proteinuria is on the high side. You can have normal GFR, but if you have high proteinuria, you are at risk of CKD progression quite rapidly. So when you have patients more in the orange and red zone, they need to be seen more than 2, 3, or 4 times a year, and they need to be referred to the specialist as well. So CKD and DKD, what's the connection? So this was the NHANES data, old data, but I just want to think about that, is this a true data? So they say that 32 million Americans have type 2 diabetes, which is roughly 10% of the population. What do you think, what percent of population has diabetes? Is this 10% or more than 10%? To me, it's more than 10%, because Dr. Aziz, what do you think is? 16%. Do you think that 16% is actually, we may have some patients who they live in the blind spot and they don't even know that they have diabetes. In this data, there's 40% of the patients have chronic kidney disease. Again, under-recognized, under-diagnosed. When you combine CKD to any disease condition, that's 3 times cardiovascular risk. So the problem with these conditions is that these are a giant in making, which are under-recognized because of this blind spot, because in the beginning there is hyperfiltration, GFR actually increases. Even the microalbuminuria, when it goes up, it starts to decline with the decline in the GFR. So you don't get to diagnose these patients unless the GFR is less than 60. By that time, 50% of loss has occurred. So really, you, in the capacity of primary care, can be very, very effective in managing these patients before they even hit the nephrologist or other specialist clinic. So really the approach should be, what is your individual patient doing, and looking maybe from the population health perspective as well. When you talk about the individual patient, so think about your patient in the clinic, like somebody who has high blood pressure, who has diabetes, who has coronary artery disease. Are they getting some ASCVD protection? Is what's happening with their blood pressure control, their cholesterol, their preventive strategies? And then population. So if you have 2,000 patients in your clinic, what percentage of your patients, say if you have 2,000 patients, 1,000 of them are diabetics, out of that, do you have 60% with their hemoglobin A1C less than 7 or something? And this is what we do in the population health. I have in my healthcare system, we have 300,000 patients in the system, and then we have population health team, and we exactly know the KPIs, what percentage of patients have hemoglobin A1C below a certain limit, the blood pressure, the cholesterol, and some other KPIs. So this is the type of modality shift or mindset shift that you think from an illness base more to a wellness base. I know we have some lifestyle, and more looking at the population based as well. So I don't know if I missed a slide, maybe. So I will be showing, as I mentioned, some of the trials. Back in early 2000s, we had this renal trial, which showed that losartan was better than placebo, not just in the cardiovascular and hypertension, but in the nephrology or renal outcomes, which is doubling of serum creatinine, renal death, and ESRD. The similar trends were seen in IDNT, which is irbesartan diabetic nephropathy trial, and this shows superiority of this drug against a calcium channel blocker and placebo as well. And then we had a 20 years gap when we did not have a meaningful trial. If after IDNT you see that there are certain drugs, you see this evocentin, and there was a trial for atrasentan in 2010. I still remember I was in fellowship talking to my chief. He said, I'm bored because I have a patient who is on the maximum tolerated dose of ACE inhibitor. They still have proteinuria. We don't know what to do. He introduced me to this trial. Actually, I enrolled some patients in the trial. The trial was stopped early because of hyperkalemia as the side effect. They did secondary analysis later and found the drug was effective. It's just like trial design was defective. So we kept trialing different drugs until we hit the SGLT2 inhibitors. And we already heard about SGLT2 much, so it will be redundant for me to go into detail. You all know that the SGLT2 are your glyphosins, DAPA, CANA, EMPA. I saw a fourth one as well. They are really sodium glucose linked transporters. So you see all these transporters on the luminal sites in the kidney proximal tubule. When these drugs block those receptors, basically you start leaking glucose and sodium in the urine, and this is a good mechanism. We just say, so these patients pee the glucose. When you do a dipstick, you see glucose positive. Don't get started. So looking at the SGLT2 trials, it started with the EMPA-REG and CANVAS. So those were mainly cardiovascular trials. So the CREDENCE was the first trial which has the renal outcome as the primary, and they were majority of these patients for diabetes, and all of I will present 3 or 4 trials. They incrementally try to answer a different question. So you will see some similar in these trials. One is that they reduce proteinuria, other is like initial, there was a decline in GFR, and then the drug actually fared better, and you see the trend in different trials. And each of these patients were on the maximum tolerated dose of ACE inhibitors. So primary outcome, there was like a 30% risk reduction in this trial for the patients needing dialysis, patient having serum creatinine which persists for more than 30 days in the double or death from renal causes. So if you treat 1,000 patients for 2.5 years, 22 would be treated with this drug canagliflozin to prevent one outcome. So you basically have a population of 1,000 patients, you give this drug in 22 patients, and one will be prevented from going on dialysis. So you are trying to save some lives. DAPA-CKD was the other trial. As you can see in the graph, that initially there is decline in the GFR, then the GFR is sustained. So instead of having that slope which I showed you, the slope is more flatter. And then that's where after like a year or 2 of consistent use, you see improvement. So what was different in DAPA than the previous trial, that now they added patients with or without diabetes. So imagine these drugs, they started as diabetes drugs, but they started to show cardiovascular benefits, now renal benefits, and people are crossing the boundaries to test these drugs beyond diabetes. So serendipity, you start something in a different disease condition and you found the benefits on the other side. In the first trial, the GFR cutoff was 30. Now they wanted to be a little, aggressive, and the GFR cutoff was 25. And these patients were also on the ARB. And not only that, there was improvement in the renal outcomes, they also seen an improvement in the cardiovascular outcomes. So patients with or without diabetes fared better. And the hazard ratio is 0.61, which gives you like 40%, more than a third reduction in the risk. There was no DKA in the DAPA group, and we did not see any severe hypoglycemia in the non-diabetics, which was one of the major problem. More recently, 2022, 2023, this year earlier, this was presented and published in the NEJM. This is the EMPA Kidney Collaborative Group. So now they wanted to test this drug for GFR for 20. So first it was 30, now then 25, now 20. And they also test this drug with patients with almost negligible proteinuria. So somebody who has no diabetes, who has negligible proteinuria, and there were patients with GFR just barely above 20. And this shows like a hazard ratio of 0.7, so a third of reduction in the risk, which is pretty significant. 1/3 reduction in risk of going on dialysis or dying is significant. This is a busy slide. The point is that EMPA worked in patients whether they have diabetes or non-diabetes. It worked better with across the GFR stages, whether you are above 20, more than 30, more than 45. I think if there was no albuminuria, you can see the last few rows. It's in the middle, but it started to show its benefits. So as patients are having proteinuria, these drugs help across the GFR stages, whether you have diabetes or not. So if I summarize these 3 trials. So the timeline, the Credence, DAPA, CKD, and EMPA, 19, 20, 23. These are like large trials, like 4,000, 6,000 patients. The first was with only diabetes, the last 2 with or without diabetes, and they really pushed the GFR from 30 to 25 to 20. So really, they want to see if the patient who has already achieved CKD4, do they get any benefit or not? And every time they showed improvement in renal outcomes, cardiovascular outcomes, 1/3 to 1/4, maybe a half reduction in the risk factor. So we just heard about the side effects of SGLT2, which was a problem, and I can probably skip this slide. But the point is that you can start these drugs now above the GFR 20, and just don't do it once the renal replacement therapy is started. So what are the other targets? What are the other new drugs which are in making? The drugs that focus on inflammation and fibrosis, MR2 receptor blockers, which is finerenone. I'm sure all of you are familiar with spironolactone and eplerenone. Spironolactone is low specific, has lots of side effects. Eplerenone is not very potent. Finerenone is non-steroidal. It's very specific and it's very more potent. And this was the Fidelio trial. I actually had 2 patients in that, and the patients who were in the trial actually showed benefit in the study as well as I personally seen that. So this is similar trial, GFR between 30 and 60, and then their proteinuria as well. Hyperkalemia was the side effect, so you must watch potassium in these patients. And I think they looked at the similar outcomes, kidney failure, decline in GFR, renal death, and cardiovascular outcomes as well. And this drug also showed similar promise to SGLT2 inhibitors for the cardiovascular as well as the renal outcome. So the hazard ratio was 0.82 in here. So really the number needed to treat for one primary outcome was 29. Not only that, this helped with the slowing the progression of kidney disease, but also with reduction in proteinuria, which is one of the tangible marker you all follow. So you follow these patients with proteinuria every few months. They are on maximum tolerated dose of the drugs. You cannot do anything now. There are few drugs as well. The other drugs which are gaining popularity are the incretin-based, like the GLP-1A, RA as well, which have renal benefits in addition to their diabetes and cardiovascular benefit. So we just heard that it's important to look at these things from multiple aspects, not just one drug. So this was the treatment algorithm by KDIGO, very recent, that if the patient is in your clinic, what will you do? So everybody needs lifestyle. We have, I know that in the conference there is emphasis on the lifestyle. What is your first-line drug therapy for somebody who has CKD and DKD? So this is important. This is very practical for you. If the GFR is more than 30, metformin. If the GFR is less than 30, you stop it. SGLT2 along with metformin are the first-line agents in DKD. Your additional therapies, if glucose is not controlled, GLPs and your DPP4 inhibitors, which are your gliptins, they are taking priority on other drugs. So now you have actually an algorithm that what's the hierarchy of the medication which you can prescribe to a patient in a stepwise fashion. Some of the other important aspects, aspirin has been discussed heavily this morning, and it's again important for kidney world as well, for secondary prevention. Cholesterol is important. In kidney and CKD, once they are 3 and 4 stages, you use a fire and forget strategy, so start them on middle of the run statin with ezetimibe, rather than treat to target. Make sure their primary prevention with vaccination. You try to minimize their pill burden, no NSAIDs, no dual RAS blocker. You make some dosage adjustment as the GFR declines in smoking, exercise, etc. So coming towards the end of the presentation, last 3 or 4 slides. If you look at the historical perspective, back in 1980s, if there is no specific therapy, which is the bottom left side of the screen, the GFR decline is minus 12 milliliter per minute per year. So if somebody has GFR of 50, next 4 years, it will be 48 reduction, and they will be on dialysis. With the renal IDNT, you saw that we improved from like 10 to maybe 6. So now the decline is 6% of function per year. But with the most recent trials, the decline has dropped from 6 to 2. So instead of having that slope, which I showed you in the beginning at a very slippery slope, now the slope is straightening and the GFR decline is reducing. So this is my second last slide. This is from KDIGO, and this is what I was mentioning, that if you may pay attention, this might work. So everybody should have weight, smoking, and exercise and diet. We discussed about the first line agents, which is the metformin as SGLT2, RAS blockers, and statins. Once you have to go to the second line, so you have GLP-1 RAs, aspirin, and the newer finerenone, which is the MR2 blocker, and everybody needs blood pressure control and lipid management. So in the end, these are the ABCs. So A for ACE inhibitor or ARB, again, first line. A for aspirin, which is the secondary prevention. So B is for blood pressure control, predominantly through the ACE inhibitor or ARB. So you have A for ACE inhibitor, B for blood pressure, C for cholesterol, statin, KDIGO said it's the first line. D is for diabetes. DAPA is FDA approved among the gliflozins in the renal, but anyone will be okay. So ACE inhibitor, blood pressure, cholesterol, diabetes. Don't forget their diet and vitamin D. E for exercise. F is the finerenone, which is the MR2 blocker. So this is now we are going into the second line agents. G is the GLP-1 or A, and S is the smoking cessation. So really you have those ABCs, A for aspirin, ACE inhibitor, B for blood pressure, C for cholesterol, D for diabetes, with DAPA or gliflozins, E for exercise, F finerenone, GLP, and smoking cessation. So this is my journey. I started with in front of my, my teachers are sitting in front of me, so I'm very happy I'm presenting in front of them. Then I went to residency in UPMC, and this is the Penn State, which is my new kind of home. I've spent more than 15 years now there at single place. So I did my fellowship in nephrology, my master's in public health sciences. I'm currently doing an MBA through their business school, and this is our nephrology team at Penn State. So thank you very much, and I can imagine we do the questions in the end.
Thank you, Dr. Umar, an amazing talk on diabetic nephropathy. This concludes the talks of this session, and now I would like to have comments from the panelists and the chairperson. I think Professor Javed Akram is busy somewhere, so we start off with Professor Azaz Mand for the comments on the talks.
Thank you. I think it has been an excellent session, and we have heard speakers on NAFLD and on the cardiometabolic aspects, and also on diabetic nephropathy. And I think most of the things have been re-emphasized as far as the current developments are in place. I have a question to Dr. Umar Farooq, that do you think that with this menu of drugs that are available to us, it is important to individualize the treatment and to see that which treatment fits in the best? You have given a very nice A, B, C, D, E, F to practice, but do you think that it is important to individually look at every